All right, welcome back to the No Morning Show here on CTT. I am Natalie Legore, and in today's spotlight, Professor Hariharan Seetharaman to talk to us about the third primary dose of the COVID-19 vaccination that the ministry will be rolling out shortly. Good morning to you, Dr. Seetharaman.
Good morning, Natalie. Thanks for having me.
Thank you so much for joining us. So, of course, when the announcement was made on Saturday and the ministry, the CMO, the other doctors there went through Dr. Boyce, the minister, to explain what this was about. But I think a lot of people get lost in the translation sometimes. And I just thought it was important for us to get back to the basics of, you know, why do we need a third primary dose of the vaccines?
Okay. Let me start from the basics again. The vaccine does two things. One is if we are aiming for a reduction of transmission, that is one goal. The other one is reduction of severe disease, hospitalization, and death. That's the other goal. Now, no vaccine in the world so far developed has completely reduce the transmission. When we developed herd immunity, the smallpox was eradicated, the polio was eradicated because the transmission, there were not enough people to transmit. Everybody was immune, and that is how the transmission died on its own. But the herd immunity is the reason for actually stopping the transmission. Now, what we know from the current COVID vaccines are that they actually are more efficacious in preventing death, hospitalization, severe critical illness. And until the Delta variant and Delta Plus variant came in, all vaccines, irrespective of the brand, all vaccines had 97 to 100% efficacy in preventing severe disease and death. Now, when we measure antibodies after vaccine, that is what is commonly being done. So there is a lot of debate going on in the scientific circles whether a third dose, or the booster dose. We can go and dispute the semantics of it, but it's actually meant to boost the immune system. So some people want to call it booster. Okay, we can say it as a third primary dose because what happens is that over a period of time, including the vaccines which are highly efficacious, such as Pfizer Biotech, which we have, and Moderna is the most efficacious so far. All of them, over a period of time, after 6 months, there is a waning of the level of antibodies in the bloodstream. Now, we all know that COVID virus gets into the airway passages, the nasal passage, the throat. It stays there, and when it enters the bloodstream to replicate itself, that is when the antibodies are ready now to come and attack the virus and clear the virus. And that is what happens in all the vaccinated individuals. Now, if the antibody titer, the level of antibodies, is not adequate to do that, there can be breakthrough infections, which we are seeing. And especially because of the Delta variant, the efficacy to prevent transmission has come down very much. And unfortunately, the efficacy to actually reduce the hospitalization as well as the reduce the severe illness also has come down, unfortunately, but not miserably low. I must say that the studies are very well established now that from 93, 94 efficacy rate, it came down to 86, 82 in that range, and for AstraZeneca it was much lower. And also the Sinopharm, it was much lower in the 60s. And that is why we are seeing a spike in the number of COVID cases. So late October, FDA got all the data to see whether a third primary dose is necessary for all adults 18 to 64. They analyzed the Pfizer BioNTech, Moderna, and the Johnson and Johnson vaccine, which was available in the USA. Previously, UK had already tried and published what we call as a heterologous boost. That means if you take one brand of a vaccine and 6 months later, if you take another brand of the vaccine, there was better, immunity, and there was a good level of antibody titer. And so the UK study and US studies have now pushed the FDA and the CDC to recommend that 18 to 18 plus, I mean, whoever had vaccines can go for a third primary dose or a booster dose, whatever we call it. But in the context of Trinidad and Tobago, I know that we don't want to rush to give everybody. So I think the government took a decision based on the availability of the vaccine as well as the most vulnerable. So at this point of time, we are choosing the 65 plus for the third primary dose, and also immunocompromised people, HIV or cancer immunotherapy, and there are many congenital immunodeficiency syndromes, people who are on immunosuppressive drugs. These are the people who are the primary vulnerable people, and I am hoping, and I am ready for it actually for when government says that yes, the frontliners, ICU emergency physicians and the hospital employees are also vulnerable. So I think based on the availability, I think they will extend this to the third primary, because I must say that there we do see breakthrough patients, although not much. We do see some breakthrough patients, especially I told you the Sinopharm vaccine. There are studies which show that the breakthrough infections and the efficacy rate is considerably, I mean, lesser than the other brands of vaccine. So we do see people who had Sinopharm having some sort of a COVID. Majority of them get away okay, but very few people, very few old people. And the study specifically says that 75 plus are much vulnerable for the breakthrough infection and the severity of severe illness. So
Now,
I think this is the right
Professor,
move to first include this group of people.
uh, I am trying to figure out where to start with all the information that you just gave me. But is it that you're suggesting that, after 6 months of the first two doses, we're seeing where we need a third additional dose? Are we to anticipate that going forward, we might need to have a booster shot every year if the efficacy isn't holding just after 6 months?
The I told you the debate within the scientific circles is big, is surrounding the whole gamut of immunity. We are now jumping to end this epidemic, and so we are looking at the antibody titers, which is what we call as a B cell immunity. And when this B cell immunity we titer level goes down, they are panicking because we are getting some spurts of the disease in certain pockets, and also we are much more predisposed to variants, and that is why the proponents of this third dose want to say that until we develop a full herd immunity, it is better to take a third dose. But the opponents of this one, including many scientists in the WHO, are saying that the antibody titers is always misleading, because there are some B cell immunity and T cell immunity. T cell is what we call as a cell mediated immunity, which is long term immunity. And from the behavior of these type of viruses, the scientists, virologists know that the measles type of vaccine and many other vaccines have induced T cell immunity, which goes for decades. So it is still premature to say that we may have to have every year booster like influenza, which is not always there with this type of virus. We are now, the scientific community is divided in whether we need the third primary dose. The only reason we are now going for this third primary dose is because to keep the antibody level and the titers at a higher level, so that we can bring an end to this epidemic. But I am hoping that the T cell immunity and the memory cells will take over, and we will have long-term immunity, and that is the behavior of this type of virus. Hopefully, the coronavirus, the SARS-CoV-2 also behaves the same way. They have plenty, studies on these viruses, coronaviruses. So the behavior pattern is like that. So we will have we will have a long-term immunity, and that is how the first SARS and the MERS, which is Middle East Respiratory Syndrome, which both are coronaviruses, they all came to an end because of that. Because we do have lots of different types of immunity, which we are not taking into consideration when we go for this third dose.
Doc, tell me something. When we're looking at, the COVID-19 pandemic and here in Trinidad and Tobago, and the fact that we're talking about a third additional primary dose, do we have the numbers to tell us the percentage of breakthrough infections that we've had and also deaths?
Yeah, I mean, breakthrough infections currently stands at 5 to 6%. So 93 to 94% of people who are coming into hospital are unvaccinated. So the 5 to 6% who are actually elderly, 70 plus, who had a breakthrough infection, because of their comorbidities, they go land up in an ICU. For example, a patient has COVID in the throat, because we swab in the throat, they turn to be COVID positive. So they go into the parallel healthcare system. Whether they actually deteriorate due to COVID or not, because they can deteriorate due to the comorbidity. For example, a patient developed an upper GI bleed, that means bleeding into their tummy, and they deteriorate, and their blood pressure goes down, and immediately we have to institute the critical care support, where that will go into a COVID death. So not necessarily that. It's very difficult to exactly know whether the COVID was the reason why the patient developed an upper GI bleed. I mean, it's very difficult. But once they are COVID positive, that means that is a breakthrough infection. But if the COVID actually involves the lungs, there is a pathology of the lungs, and it typically goes like the usual COVID case for the mortality. That is the statistics which we have to take, and I suspect at this point of time it is very minuscule, and it will be less than 5%. And but the overall breakthrough infection and the admission to hospitalization here in Trinidad is in the range of 5 to 6%.
Can we say if the breakthrough infections are with the Delta variant predominantly?
Most likely, because we don't do the genomic studies in every study, every PCR, because PCR will just tell us. There are some PCR machines, and there are some labs which have that capacity and that capability to tell us that within the PCR they may tell you the variant, but not all PCR tests will tell us the variant. It has to be specifically done, and we have to use a special probe to do that. And if we can collect that data, we will be able to find that there is a large number of Delta variant, I feel, because the study which the CDC and the FDA used was from 9 states in the United States. And in all those states, actually, more than 50% of their infections, the current infections, were due to Delta variant.
So is it that the vaccines aren't protecting us against the variants?
No, they are protecting, but the efficacy of the protection has come down, as I told you. From 93, 94 was the original, the virus. We had the Moderna as 94% was the top, and even Sinopharm had studies of 82 to 84%. AstraZeneca was around same in the 80s, 80 to 84%. It depends on the country where they studied, but it was in the 80s. But what happened with the Delta variant? It all came down. I mean, the Sinopharm, AstraZeneca came down to the 70s and 60s, and even the best vaccines such as the Moderna and the Pfizer came down to 80s. So The breakthrough infection is not new. If you talk to any virologist, immunologist, they will say that 100% protection is not possible with any vaccine. All that we are trying to do is to get majority of the people get immune to this virus so that we can develop the so-called herd immunity, and there won't be any person there to for the virus to go and lodge and replicate. And that is what is happening, because when the virus, there's a race between the humans and the virus. Why variants come in? Because we are trying to prevent them coming into us, and they are finding ways and means of actually evolving themselves, mutating themselves, so that they can get a better attachment, because they need to survive. So this is a race between the humans and the virus. So if we go and vaccinate ourselves, then when you have immunity against the virus, then there won't be people for the virus to actually get in, and that is the whole concept of herd immunity. So
See, Professor,
the more
something
and
I'm
more we
always
have, sorry. Yeah.
something I'm always curious about for the people for the 50,000 people who have tested positive for COVID-19, why do they need to get vaccinated? We were always told that our bodies have mounted that response. If they've caught the virus and they've survived the virus, why do they need to get vaccinated?
That's the same reason I told you the antibody titers definitely go down. I mean, what we can measure in the blood as antibodies, they go down after 6 months, and it is definitely what we are trying to do here is to prevent them again coming into a hospital. When we have the vaccine, why don't we use it and just give them a little more better protection? So as I told you, we cannot completely 100% stop breakthrough infection. So we are choosing people who are much vulnerable to this infection. And I must say that there is nothing like influenza can reinfect a human. And here I know there is very minimal evidence for reinfection in the same person. It is still going in and going to other people, but the reinfection rate has come up now because of the variant. Initially, when there was one type of virus, it was in the level of a case report. Once in a where somewhere in Hong Kong there was a case, there was a reinfection. But with the Delta variant and the new variants, there is much more transmissibility, and the virus has now the potentials to enter the human being, even though they have the antibodies. And if the antibodies level come down, they are able to infect the human. And that is why we are now trying to get these people the antibody titer until we can get the herd immunity going. Yes, I understand that 500,000 people had vaccinated, but you know that we did have the vaccine which was a little lesser efficacious, even with the AstraZeneca and the Pfizer in Europe. You know that there were spurts of reinfection, and the spurts of the variants coming in, and that is why they are going in for the third dose.
We just have a minute, Doc. Could you just please remind us of the people who will have to start getting their third primary doses? You said those who are immunocompromised, those 65 years and older. Who else?
Immunocompromised, I mean, people who are, HIV, people who are on immunosuppressant drugs, and so far those are the ones authorized by our government. And I am hoping that like other governments, like they will also include the frontline workers, healthcare workers, who are also much more prone for this type of a variant infection now. And more when we have the drugs like molnupiravir, and we will have some nasal spray vaccine which can provide local immunity, and more into this disease, I am sure that we will be able to win this race.
All right, Professor, thank you so much for speaking with us this morning.
Thank you very much for the opportunity. Anytime.
You're most welcome. Professor Hariharan, Seetharaman, they're talking to us about the third primary dose. He said semantics, you can call it a booster shot, because really and truly what's been happening is that the efficacy of the vaccines after 6 months have dropped, and therefore they're deciding to give people a third dose to ensure that they bring that up, because they're still having reinfections, you're still having spread, and they think that will help to control that. They believe it's because of the drop in efficacy where we're having these infections. Yeah.